Now, managing the anaphylaxis isn't just about giving the epinephrine. You also need to follow a structured emergency approach starting with the ABC. In this section, we will focus on the airway, breathing, and circulation, which are often the first to deteriorate in the cases of anaphylaxis. So, let's dig deeper. Do you know that airway swelling is a leading cause of death in anaphylaxis? You might see the stridor, hoarseness, or even drooling if the swelling is severe. You need to do what? You need to act rapidly. You have to call for the airway support before it's too late. And if there is a voice change like stridor, you need to get the ENT and the anesthesia involved as fast as possible, like right away. Anaphylaxis often involves the lungs, especially with the bronchospasm or the airway edema. Always give a high flow oxygen even if saturation looks okay at first. If there is wheezing, start nebulized bronchodilators immediately. And if breathing effort worsens, don't hesitate to step in with the bag mask ventilation. So, in real-time emergency situations, subtle changes can signal big troubles. If someone's suddenly quiet after wheezing or there's oxygen saturation drops despite the oxygen available, you are heading towards a respiratory collapse. So be vigilant, and that's your cue to act fast. And one thing you always have to keep in mind that in anaphylaxis you are dealing with a distributive shock, which means there's a massive vasodilation and fluid leaking into the tissues. Patient may feel dizzy or they may faint or have a dangerously low blood pressure. Your first move should be epinephrine intramuscular. That's it. Then lay them flat with the legs up and start the fluids if they are needed. If the patient's blood pressure doesn't respond to the intramuscular epinephrine injection, you have to go for the intravenous fluids very fast. Adults may need up to 2 liters of the IV fluids, and for those in refractory shock, start an epinephrine IV infusion and titrate based on their body's response to them. And you have to remember that antihistamines and steroids don't reverse the shock, either the distributive shock or the refractory shock, but they help to prevent the recurrence. If the patient doesn't perk up after 2 IM epinephrine doses, that's a signal to escalate. This could mean the refractory anaphylaxis or evolving shock. Get critical care involved early and consider ICU transfer for monitoring. To summarize this all up, protect the airway early and support breathing aggressively. Oxygen helps, but epinephrine is your best ally. And remember, waiting too long to secure an airway is a mistake that can cost the lives. So, to wrap it all up, the circulation part, you have to treat aggressively and you have to treat early. Epinephrine is still the king of all the products that will be used, and fluids are your backup option. And remember that it's okay to overtreat your patient, but what's dangerous here is your hesitation to treat. Better safe than sorry in these situations, right? And that's it. Now is the time to move to the next chapter of this course.